is properly set up. All the workstations are working, and it's a few minutes after 5 now here in Western Europe, and looking forward for about 90 minutes ahead for in-depth clinical case review and questions and answers before we close at our time 6:30. There are a few housekeeping rules we'd like you to adhere to in order to make sure this meeting is productive and effective for both yourself, the speaker, as well as for us. One of the most important reasons so we can help you when you have problems is to make sure you keep your chat window open in the Teams. So if you haven't done
can go back to the mediastinal window setting, right 7, and you may increase your sensitivity by playing with the MIP mode. You go to MIP, you see the selection average, you go to MIP. I suggest to increase your slice thickness. You may increase by writing 10, for example. You return and you have the pulmonary arteries in the MIP mode. You inspect the pulmonary arteries. It's not really obvious. I don't see anything really annoying. So I suggest when you inspect pulmonary arteries, not doing conventional viewing, but going to spectral CT viewing first. And you can play with mono E, you can play with Z effective, you can play with iodine content. So I suggest, and that is the simple tool, you go to recent, for example, and you have this tool, conventional Z effective. You select this one, conventional Z effective, and you can compare side by side the results. You go to the left upper side of the box and you go to iodine density. Iodine density, and you change your window setting by pressing the central button of the mouse, like that. And you go to scrolling button on the left side. And we can inspect the lung window, the lungs. You go, and here you will see appearing like a perfusion deficit here. You see? So you can change your display by going on iodine density, and you go to Z effective, for example. Z effective, and you see there is a triangular shape defect here in relationship with some pulmonary embolism. So here, if we go there, you see there is a clot here obstructing a peripheral branch of the posterior basal pulmonary artery on the right side. You see, you may have artifacts here. It's the old data in 2016. It was at the beginning of Spectral CT. It has disappeared now. And you can correlate your findings here with this viewing, or you may go to the other display. If you go to recent, you go to fused 1+2 mono E, you click on it with your left-hand side button, and you have the display I showed you before. You see the perfusion defect, and you can play with the fusion overlay. You will decrease the opacity here. You can change the mode average to MIP. You will better see the vessel. I modify the opacity here, and you see that's the PE. So there was a peripheral PE, and most of radiologists missed this clot. But added value here, or from the icon, was certainly to detect very tiny clot with some perfusion defects in front of the occlusion. So it has been shown in the literature that there was some added value of spectral CT, and the added value showed there was some benefit, a small incremental benefit, a few percent for the detection of occlusive segmental and subsegmental pulmonary emboli. So that's it for this case. Are there any questions for this case? arteries. You see there is a pericardial effusion. So there is something very strange. So there is a suspicion of peri-aortic hematoma here with something very strange just around the pulmonary artery. So I suggest to compare now with the true non-contrast CT acquisition. You double click on the series and you have the compare mode. Here you have the true non-contrast on the left side. And you see that if you see here surrounding the aorta, you see it's dense. You may select region of interest by clicking on the circle. You draw a circle here. You see average is 43. What is interesting, you can go to the right series. You go to conventional and you have all the spectral CT values, and you go to virtual non-contrast. And here you have the virtual non-contrast. If you compare this region of interest with this one, it's quite close. It's 39.6, 3 ounce-filled unit difference. And here, if you put a region of interest by clicking on the circle button and the left-hand side button, you draw a circle just along the pulmonary artery, and you see if you click the button of the region of interest, you see that the value of virtual non-contrast is 43, and here it's 61. They may have some difference between the values between virtual non-contrast and true non-contrast. We did an experimentation. Sometimes there was a difference value of 15 ounce-filled units. But in some situation, you may obviate the true non-contrast acquisition and go directly to contrast medium injection and playing with virtual non-contrast, and you have a good idea of the natural density of the organ, of the perivascular environment. So what is the explanation of that? The explanation is the following. It has been published by several authors, and Salim C. Mohamed is from Lyon. He did a series about virtual versus true non-contrast dual energy CT imaging for the diagnosis of aortic intramural hematoma. And they conclude that virtual non-contrast is very useful in emergency conditions. You see here the summary of the findings between virtual non-contrast and the CTPA. And what is the explanation? It's into this paper in 2007. The author explained that there is a common adventitial layer between the aorta and the pulmonary arteries. So you can propagate the hematoma from the aorta in the adventitia to the pulmonary artery. Sometimes it can obstruct the flow into the pulmonary artery, and it can cause also dyspnea. So that's interesting. It's quite rare, but it illustrates the added value of spectral CT in the case of aortic emergency and pulmonary arteries involvement by hematoma. Are there any questions concerning this case?
No, there are not. No.
Okay. I have another interesting case. It's a 70-year-old female with back pain, and she was referred to spectral CT to see what was the cause of the back pain. So you have to inspect the chest CT, and see what is interesting. So I go back to RADUP and I exit the case 5 series, and I will select case 6. You select this case and you load to Spectral CT Viewer. You load it. Okay, so I invite you to travel into the chest volume, playing with the different window settings and see what is abnormal. You see, there is upper abdomen acquisition also and lower abdomen acquisition. It was a total body CT. And we don't see anything very special, maybe some lithiasis in the gallbladder. I go up in the mediastinal window setting. We don't see something interesting. So you go after that to the long window settings. You write 6 on your keypad. You travel with the central button or your arrows on your keypad. You go down. There is almost nothing to see. Some linear atelectasis at the left side of the lung, the left basis, nothing else. Don't forget to go to bone window setting. You go to number 5. And there you can inspect the bone. She had back pain. And you see some osteolysis in the body of the vertebra. So the explanation of the back pain was osteolysis, but you have the cause of osteolysis on this CT scanner. I invite you to go to the mediastinal window setting and you go to number 7 to select mediastinal window setting. And you will go to the spectral CT data. You will select preset. You go to general, for example, or recent. It's up to you. But you have to select this one, mono E iodine density PE, and you double click on it. You double click on it. So you have the iodine overlay density, and you can travel into the chest volume. Here, you see there is something with high content of iodine. We will focus. You can pan if you want, display the region of interest. You can zoom with the right hand side button. You zoom. And you can measure the iodine density. You take your circle, region of interest, you draw your circle, and you see that iodine density was 1.2 milligram iodine per milliliter. You can play with the overlay and opacity, and you see a soft tissue mass in the left breast. So we did a nice study with Köln in Germany. It was more than 100 patients with breast masses. And by playing with iodine density and by standardizing the value by the iodine content, we were able to discriminate by the iodine value the benign nature of the malignant nature of the breast masses. But you have to normalize with the iodine content. You will get better results, more consistent results. If the value were above 0.8 0.8 or 0.9 iodine milligram iodine per milliliter, it was suggestive of malignant disease with a sensitivity and specificity approximately of 95%. So that's interesting. If you have an incidental finding in the breast, you can try to characterize this finding with iodine density. So this breast mass was invasive ductal carcinoma, grade 2. I will show you on the PPT slide. And that's the publication in European Journal of Radiology. And it can be useful to do a general inspection for incidental findings and spectral CT viewing. Are there any questions about this finding and this clinical case?
So no new questions. There was one additional question about the last case, just came in after, about whether or not the virtual non-contrast can be useful to different, for calcium scoring. There's been some answers given, but maybe you can give your take on that, Professor Koch, if you will.
I know there are some publications about virtual non-contrast and calcium scoring, but I have no this publication right in my head. So I think that's very interesting. And there are some nice correlation, but I don't know exactly the details of the publications. That's certainly interesting.
There's a few more questions.
Let me see. So there's a question I would like to ask Professor Koch if he is exploring the use of calcium suppression or even the EDW percentage, the maps in some kind of cases as the vertebral osteolysis has just shown, as he has just shown.
It's quite difficult. We try to do calcium suppression in some cases. Sometimes we have a nice illustration of bone marrow replacement by a soft tissue. It can work in some cases. Sometimes it doesn't work. In this case, in the present case, it doesn't work. So we don't use in clinical routine. So we don't know exactly what is the background of the calcium suppression. Maybe we have to do some experimentation with cadavers to see if there is a blood component, or we don't know exactly. So we don't use it in routine.
And did you have the chance already to look at that electron density mapping?
Sorry, the
electron density maps.
Not on this case. Not on this case. We are working on that, but inside the lungs, and we did some experimentation. But in the lungs, it's quite difficult to use electron density. It's decreasing the noise, but for characterization of material, it's quite difficult. It needs more experimentation.
Yeah. Okay. Well, thank you for the answer. So there's another question, and Maya is asking whether inflammation can cause similar values in the iodine density.
Sorry, can you repeat?
Whether or not inflammation can cause similar density values if you measure your iodine density concentration.
Yes, there is a paper. There are some overlap between the inflammatory, sorry about that. There is some overlap between, for example, lung cancer and inflammatory masses in this case. The authors have shown that there was a higher iodine uptake when the mass was inflammatory, and less uptake if it was a cancer, and it has to be normalized by the aortic content. The iodine content also differs if it's a high-grade tumors compared to low-grade tumors. If it's a low-grade tumors, it will take more iodine than the very aggressive tumor. But there are some overlaps. It needs more works on that. But there are some interesting findings in inflammatory tumors and malignant tumors, but there are different values of iodine uptake, more iodine uptake in inflammatory tumors compared to malignant tumors in general, but some overlap.
Okay, thank you very much.
Okay. If it's okay, we can go to the clinical case number 7. It's a female patient with a previous thyroid carcinoma, and she was referred for spectral CT acquisition for follow-up. And I ask you to inspect the lungs and to see if there are some lung nodules and try to characterize lung nodules with the iodine density, for example. So I select RADUP. This one. So case number 7, you go to Spectral CT Viewer. So this patient has been operated. I suggest to go directly to the long window settings. You write 6. And you know that you will increase your sensitivity if you go to MIP mode. You go to MIP mode, left-hand side button, MIP. You increase your slice thickness by the shift button, left-hand side button. You go to 10 millimeters, for example. You go to the scroll button. You select it there on the left side, and you see there is a lung nodule at the left apex. You go down. Another lung nodule. Here you have another nodule. There are different lung nodules. Here you will see a right lower lobe consolidation. We can go back to this consolidation after. We can go to the spectral CT data, and I invite you to go to preset. You go to general, and you go to the bottom, and you will take the last display, fuse 1+2 mono-E iodine density LN like lung nodule. You select it by clicking on this box, and we can go to a lung nodule. Here is a lung nodule. You can always play with the opacity. I try to find the nodule. Here you go to opacity. You remove the opacity, the overlay opacity. We can go to long window setting here. We will go to average, and we will decrease the slice thickness, for example. Perfect. So here is the lung nodule, and you can play with the opacity. You can zoom. Right-hand side button, you select zoom. The pan button, you take this one on the left-hand side column. You displace your volume of interest. You take the region of interest. You put a circle inside the lung nodule and see that the iodine density is 4.76. That's too much. So there are some publications dealing with lung nodules in patients with thyroid cancer, and by using spectral CT data, if you are using iodine content and the value above 3.60, you can characterize lung nodule, and it's consistent with thyroid carcinoma metastasis. You have always to normalize with the aortic content, but it has some value for characterization of lung nodule. You see, in this case, the patient had some operation. It was a papillary thyroid carcinoma. So if I go back to the case, we can dezoom the selection. I go to left-hand side, I dezoom, or I can do reset all. Reset all. You have everything reset. And here you have always the display with the iodine overlay, but the opacity is near 0. Here is 0. You see here, you have a consolidation with some surgical clips here. So you can inspect with lung window settings, you write 6, and you have like a granity here, like you can encounter is some lung infarction. So here it was like a lung necrosis in the right lower lobe. And if you take your opacity to the right, you can increase the slice thickness to decrease the noise. And you see if you put your region of interest, you may have iodine content, iodine no water, 0.68, almost nothing, but it's more noisy than iodine density. If you put iodine density, you have 0.18 milligram iodine per milliliter, almost no iodine. So it was like a lung necrosis due to the surgery, and this patient had lung nodule consistent with lung metastasis from the previous thyroid carcinoma. That's it for this case. Are there any questions concerning this case?
No questions in the chat. I do have a question myself, Professor Kosch, because you show quite a lot of different, let's say, spectral results. You opened up some different viewing windows, and you use tools. Now, it feels like quite a lot of work for the evaluation of your findings, but what's your objective opinion about that? Is it justified? Is it in time and clicks? It's the right investment for the diagnosis?
No, I think it's very useful because I suggest to always work with the spectral data, SBI, in the spectral CT viewer, and you change your mode. If you have too much artifact, you go to high energy. If you have not enough iodine, you go to lower KEF. If you have high density, you don't know if it's iodine or calcium, you go to virtual non-contrast. We asked a question to chest radiologists if they are playing with dual energy CT, and most of them are not playing with dual energy CT because it's not a friendly user interface. So I think that Phillips, that's the particularity of the Icon CT viewer. It's really, really friendly and easy to manipulate, very intuitive, and we can jump to one preset to another one, and one display to another one. And I think it's not fun because, as I have shown, there are some incidental findings. We can discover more findings, more P, a lot of different stuffs. We can characterize lung nodules. We can do a lot of stuff. There are a lot of things to develop, but it's really a nice tool for me, and I'm using it on a daily routine.
Okay, thank you very much. So there's no additional questions about the case.
Okay, maybe we can go to an oncology case. It's a clinical case number 8. It's a 63-year-old male with intermittent headaches, and the HCT show multiple brain masses and a cerebellar mass. And he had a chest X-ray, and you see there is a lobulated mass in the right upper lobe. There is enlargement of the right paratracheal region, some density in the right paracardiac area. So we did a CT scanner, and I invite you to go to clinical case number 8. So we go to exit. We will select the clinical case number 8, and we can take this one. There is only one series, and we go to Spectral CT Viewer. So I invite you to go directly to recent box, and you go to conventional mono E. So here on the left side, you have the conventional view, and here you have the mono E viewing. So the chest CT acquisition confirmed there was a lung nodule or mass. You can measure it above or less than 3 centimeters. It was a contrast enhanced CT, and you see there's some density in the right upper lung mass. It's a lobulated mass. If you zoom it, we can zoom, you zoom it. I hope you are familiar with that. You can pan, you take this button, you pan. You take the density, you will select a circle. You take your region of interest inside this hyperdensity. You see that the value is 218. Is it calcium? Is it iodine? We can take, for example, the left subclavian artery. You have the density. You can displace it, 233. So it's quite the same density as the density observed in the right lung nodule. So you can play with the spectral based images, and you go to virtual non-contrast. You go to virtual non-contrast. You have erased the contrast. You see good results. There is no contrast in the left innominate vein, and here in the supraortic vessels. And here you see that there is a remaining density here in the lung nodule, in the lung mass. So it has some calcification. That's the added value of spectral CT. If you go to iodine density, you go to more spectral results, iodine density. You can measure the density, the iodine density of the mass. You see 0.78. You can go to the other part of the lung mass or nodule, 1 milligram iodine per milliliter. So there are different components inside the lung nodule. If you go to the right paratracheal adenopathy, you will put a circle, and you can also measure the density, the iodine density, and you see there is a high uptake of iodine, 3.3 iodine milligram per milliliter. So higher iodine uptake. So there are some interesting values in this patient, showing that virtual non-contrast may show calcification inside the lung tumor. It can display different part of the tumor with iodine uptake, not iodine uptake, and high uptake of iodine in the right paratracheal lymphadenopathy. That's it for this case. I don't know if you have question. I don't know if we have time for the last case.
Yeah, so we're approaching the end of the session. We have 2 minutes left, but I would love to give the floor to the audience to ask some final questions if there are any. But yeah, I look, I'm enjoying myself, and I don't mind if you go through another case, but maybe we should pause for a second and see if there are some questions from the people attending.
There is another one. I would like to ask Professor Koch this time about the iodine uptake. We have in Spain so many customers that have read your Spectral book and use it as a true guidance, but they are struggling with the threshold of the uptake. Some customers start to think that it is a captation of structure when the iodine density is above 1.5 milligram per milliliter. So we would like to know, what do you think about it, and if the threshold is not more closer to the values of 0.7 or 0.9 of iodine concentration to talk about true pacification.
Personally, I didn't do any prospective investigation of iodine uptake and lung nodules or adenopathy, because the situation is the following: that most of patients in oncology are done on other CT scanners. We are doing chest cases from emergency on the ICON, and not on a daily routine like oncology or interstitial lung disease or other stuffs. But we do only emergency cases. So I have no really the values, because I didn't do any studies on that. Okay. Usually it's incidental findings, and I think it's interesting to show the uptake. There are some literature about that, but I don't remember exactly the threshold of that.
Okay, thank you very much. So in the meantime, there's also another question that came in. It's not necessarily or not directly chest related, but the question is whether or not it's possible to characterize a lipid-rich adrenal adenoma on a virtual non-enhanced image. Can you answer that?
Yes, I think there are some publications saying that it's possible to do the diagnosis of adrenal adenoma using virtual non-contrast, comparing virtual non-contrast and enhanced CT. I think there is quite a high diagnostic accuracy to do the diagnosis of lipid-rich adenoma with spectral CT.
Okay, thank you very much. So, any other questions still? Is there?
I think I have to close the session by giving you a code, a QR code. You can scan it and give you feedback about the session. It would be very useful for the organizers. what will be your feedback. I thank you really, really much for your attention. It was a little bit difficult for me at the beginning because phone calls and I lost the connection, but it was a pleasure to share my experience with you.
Well, don't worry, Professor Koch. I think the pleasure was all ours. Thank you very much for